Hey, everybody. Thanks for tuning into this episode of the Physician's Mind podcast. This show is designed to engage the curious mind on the journey of lifelong learning and self-improvement in medicine and beyond. I'm your host, Curtis Wilkerson, and today I'm honored to have guest Dr. Daniel Gulden on the show. Dr. Gulden went to school at the William Carey University College of Osteopathic Medicine, and he's currently an internal medicine resident at the Brooke Army Medical Center, and he was a former ROTC cadet at Arizona State University. Hope you enjoyed this episode. If you like the show, please share on Spotify, Apple Podcasts, or YouTube. Enjoy. So, Dr. Gulden, you've got a very impressive resume. Welcome to the show. How you doing?
Good. It's good to be here, and thanks for inviting me.
Absolutely. So why don't you just tell us a little bit about who you are? Where are you from? What do you like to do for fun?
Sure. So I'm originally from Arizona. I did my undergrad at ASU in biochemistry, and then I went to medical school in Mississippi. That's where I met my wife. We both matched to internal medicine at Brooke Army Medical Center in San Antonio just recently. We're currently about 2 months into intern year, so it's been a little busy. But some of my hobbies include reading novels, playing games, studying financial topics, and cooking. We also like to do kayaking and hiking. So gotten out a little bit around here for that. So it's been fun.
Great. And a fellow ASU alumni.
That's correct. Yeah.
So tell us a little bit about what piqued your interest in a medical career.
So it started in the beginning of my freshman year in college, and that's when I started going to ROTC as well at ASU. I found that I really enjoyed being responsible for other people, and that's what officers do. They're responsible for other people. But I didn't really gravitate towards a lot of the combat arms stuff that a lot of our instructors try and push us towards, and I don't fault them for that. But I decided that I wanted to take care of take care of our soldiers in a more like medical way. And so I decided that becoming a physician was the right choice for that.
All right. And could you detail some of the challenges you faced and what it was like combining military training with pre-medical curriculum? I mean, that must have been the
Yeah, it
opposite of
was
easy.
yeah, it was kind of tough. What made it easier for me is that I had a lot of credits from high school, and so I was able to lessen that burden because a lot of people they were taking, if I didn't have that credit from high school, I'd probably be taking like 18 to 20 credit hours, but for me it was a little bit less than that. So it was manageable. I think a lot of it was just dividing the time between ROTC and the classes because the classes were tough, right? Once you especially get up into those upper level science courses and also getting into the third year of ROTC, there's a lot more leadership opportunities and demands that are expected of you. And so you kind of get a lot more commitment in there. But the first 2 years, they were pretty manageable. Third year was definitely the toughest. That's where I struggled the most, just because that's where you're kind of getting into that season of gearing up for medical school and then the applications. And then fourth year was a lot more chill after applications were all done and things kind of relaxed down a little bit. And after going on the interviews, I would say it was a lot easier after that. But yeah, it was kind of a challenge, especially third year of college, trying to mix both of those together.
Yeah. And as a pre-medical student, you're responsible for getting good grades, getting clinical experience, volunteering and whatnot.
Hmm.
And in ROTC, it's a whole nother world. So could you share a little bit about what your responsibilities were as an ROTC cadet in the Army?
Sure. So the first 2 years, it was mostly just, you show up to PT, physical training. I know it means something different in the medical world, but yeah, you go to physical training in the morning. You've got your classes 2 times a week. And then there's also labs that we do. So a lot of that would be either leadership labs or tactical labs. Um, and then there would be a lot of extracurricular stuff. I was part of the color guard when I was part of ASU's ROTC program. So that was just a lot of like ceremonial stuff and going to the games and presenting the colors and marching around, that sort of thing. There are a lot of other opportunities that people could do. I didn't do any of like the, what do you call it? More of like the tactical stuff. I was part of Desert Rangers for a semester, but ultimately it was just too much on my plate to continue on that. And then moving into third year, that's where the instructors really started to push us into those leadership roles. So before then, I was a squad leader as a second year. But now as a third year, you're expected to kind of get up there and be part of like the company leadership. And so I was or platoon leadership. So I was a platoon sergeant, first sergeant, um, and so those roles are basically just like personnel management, making sure that your people were where they needed to be at the right time, right place. And then as a fourth year, I was the personnel officer. And so that's just a lot of spreadsheets and logistics and a lot of planning for our labs. But yeah, it took up quite a bit of work. I would say that a significant amount of my time was dedicated towards ROTC. And I wouldn't say it like hampered my application in medical school, but it was definitely a large time sink. And I tried to spin it in a way that was positive for my application.
That's the best thing you can do. And there's definitely no shortage of spreadsheets and logistics.
Oh, absolutely.
So through ROTC and undergraduate school, you obviously succeeded. You got into med school. Did
Mhm.
you know going in what you were interested in specializing in?
Um, well, I did a lot of shadowing as part of a internship program at one of the hospitals in the Phoenix area, and it was, excuse me, it was a lot of surgery shadowing. So we were involved in surgery research projects, and so I was able to do shadowing in surgery, orthopedic surgery, and then also burn surgery. And so I thought going into medical school, I wanted to be a surgeon, but that kind of got squished pretty quickly. I realized that surgeons work a lot of hours, and I mean, all physicians in residency work a lot of hours. But I eventually changed to wanting to pursue internal medicine as a third year, just after going on my clinical rotations. And I just thought it was very interesting, the breadth and the depth of cases that you get to see in internal medicine. And I also just love the versatility of it. And as far as a career field, because if you want to practice all outpatient internal medicine, you can do that and essentially be a primary care doc. If you want to do hospitalist work and just work purely inpatient, you can do that. And then there's just a mixture of fellowships that you can pursue. And so I think that's kind of the route that I'm taking right now. I'm pretty interested in nephrology, just because I had some pretty good rotations during my fourth year for that. So yeah, that's kind of just where we're at with in terms of specialty.
And for those who don't know, what is an internal medicine physician?
So internal medicine physicians, they are generalists. They deal with adult medicine specifically. We don't really do pediatrics or OBGYN complaints. So a lot of our time is spent in the hospital. So people that get admitted from the ER when they need a longer stay in the hospital, we're the people that take care of them. So the people that come in with heart failure, pneumonia, COPD, that sort of thing, we're the ones that are managing them on the general medicine floor.
Gotcha. Thank you for sharing that. So, when you were in your clinical years, what did you enjoy most about your internal medicine rotations?
Well, again, it kind of goes back to the whole, you see a lot of different things. I remember my first couple of days on the rotation, we actually saw a patient with necrotizing fasciitis, and they rapidly deteriorated. So they came in overnight, and the person on the nights thought it was just a case of cellulitis. They were a cancer patient, so that kind of raises some red flags, like starts putting some alarm bells in your mind. But they thought it was cellulitis, so they just started giving uh, some antibiotics for the soft tissue infections, and just try to monitor them overnight. And we came to see them in the morning, and their pain was just excruciating, and they had some swelling around their knee or around their thigh that was far out of proportion as to what you would expect from cellulitis. And so we got a CT, and turns out it was neck fash. And we started them on broad spectrum antibiotics and called for surgery. And eventually they had to get transferred because our hospital is pretty rural and it didn't have the capabilities. But um, that sort of thing that you see on internal medicine it's very interesting. Um, and it's just the amount of cases that you see, like you will see so many different fields of medicine, and you end up consulting so many different specialties. And so that's what keeps it interesting for me.
And you went to med school in Mississippi, and now you're living in Texas.
That's correct. Yes.
So, what was that transition like for you?
Um, I guess in terms of like weather, it wasn't too bad because it's hot and humid in Mississippi. It's also hot and humid here, but culturally, it's very similar. A lot of good, strong values down here. Um, I get it wasn't that hard of a transition. I guess the bigger transition was just going from like medical student to resident physician and the level of responsibility that you have to take on. Because as a medical student, you're carrying maybe one or two patients at a time, and you have some sense of ownership over the patients, but you're not really coming up with the plans because the residents are doing that. And now that you're actually a resident, it's completely different because now you're carrying anywhere from like 6 to 8 patients at a time, and you're coming up with the plans that will eventually get edited by your senior or attending, but it's a lot more responsibility. So I think that's the biggest shift. Like culturally, it was fine, switching from Mississippi to Texas, but the responsibility is definitely the biggest thing that changed in terms of like the transition.
Yeah, a lot more responsibility. And pardon my ignorance, but are you at Fort Sam Houston now? You mentioned San Antonio. Is that where that hospital is?
Yes, it is.
Okay, yeah, big Army Medical Center, right?
Yeah, it's one of the biggest. I think actually it's the biggest in the DoD. Walter Reed is the other big one. But I think in terms of capabilities, we're at the top of the DoD.
So what advice would you have for somebody who's interested in being a military physician, like going back based on your experiences, things you've done right or things you might have done differently?
Well, I would say your motivation has to be, it has to be that you want to take care of our soldiers, our airmen, our Marines, our sailors. I'd say going into HPSP for the money is not really all that worth it. Uh, Lots of people have run the math, and if you're just doing it financially, it turns out to be a wash unless you do some primary care specialties that don't pay very well in the civilian world. Um, but motivation is probably the big thing. You want to actually have a desire to serve your country, because more than likely you're going to be deployed at some point. Um, So yeah, I would say the motivation factor is probably the biggest reason why you should go into the military. But there's a lot of good things that I have to say about it, like the camaraderie that you get here. It's unlike anything else. I know that there's camaraderie at civilian programs, but when you go to training with people and you see familiar faces come back in your residency, you already have those strong bonds already built. And then also deployments, like that is very difficult. But I also think it produces some really strong bonds, and you get to know and trust these people very well.
Yeah, nothing forms more camaraderie than shared hardship.
Absolutely.
So you're an Army doc now, officially. So what is
Yes.
some of the things within that culture that you enjoy the most, aside from the camaraderie and the intensity and the more responsibility that comes along with it? I mean, what is it that you find particularly enjoyable about it? And perhaps some things that are less enjoyable.
Well, I guess we'll probably start with the less enjoyable things first. There's a lot of bureaucracy. So people at civilian programs, I know that they have, um, they've got to do their own requirements for their hospital, but there's a lot of added bureaucracy with the Army. So make sure that all our training is up to date, sharp training, EO training. It's not bad stuff. It's just, it takes away time from clinical work. And so the bureaucracy is something that I have some gripes with. Um, Going into like more enjoyable stuff. So the big thing about Army medicine that is appealing is that you get to treat people that served our country and their dependents, right? And so they are very grateful for the care that they experience. Um, you'll notice when you go into the EMR, like it'll tell you what their rank was, what branch of service they're in, and what they retired at. And so it's humbling to see that, when you go into their chart, it's like, oh, you're taking care of a retired colonel who was in for, 20 years, or you're taking care of like this master sergeant that was in for 15 years or whatever. And so these people are individuals who have sacrificed for the nation, and being able to be part of their care is very humbling. And their families are very grateful for everything that we do for them when they eventually come into the hospital.
Very honorable to do, and I'm sure that's very rewarding for you. And you
Mhm.
mentioned your wife is also a physician.
She is, yes. She's an Air Force physician, also internal medicine. We're both in the same program.
So when you were applying to residency, were they flexible with that relationship? Were they able to make it work so that you guys weren't separated and whatnot?
Yeah, they put that as the highest priority. And so we made it very clear from the beginning, and we advocated uh, during our audition rotations. Um, we told them, we want to match together. We're husband and wife. It would be very difficult if we were separated. And they were very understanding of that. We interviewed with pretty much all the Army and Air Force internal medicine programs and just got our names out there. And so I think when the time came for all the program directors to sit down at Walter Reed, because that's where they go to discuss the placements for all of their new residents, our names were brought up and they knew who we were and they knew where we wanted to go. And really, there was only one place for us to go because BAMC it's an Army Air Force combined training program. And so none of the other MTFs had the capability to have both of us unless we were going to take a spot from another person. So if she wanted to go to, for example, like Eisenhower, she would have had to take an Army spot. And so it's just a lot easier for us to be at BAMC together.
Amazing. Yeah, that's very advantageous that they were able to work with you like that. So, something I like to ask all of my guests on here is to kind of go back into the years of medical school and think
Hmm.
about some of the most challenging experiences you've had and how you overcame them.
Sure. So most challenging experience, I think just adjusting to the first year of medical school. And I know you're going into the first year of medical school soon. And so I don't say this to discourage you, but it was very hard for me just because I came into my medical school with no friends, no family around. And so it was very socially isolating. And then just the amount of work that you get thrust into, it's completely different from college. And so I wasn't able to form a lot of the social connections that would have helped with like easing that burden, just because I was completely snowed by the amount of work that we were getting ourselves into. And so I would just say like the overall first year of medical school was very tough. I really can't point to like any specific hardships, I guess, other than I guess failing my first biochem exam. It was kind of funny actually. My professor pulled me aside and into his office after the results of the exams came out, and he said, I noticed that you're struggling, and we want to make sure that people um, can get on the right foot pretty early on. And so he said, what did you study in undergrad? And I said biochemistry, and he said, oh, that's kind of interesting. And he said, where'd you go to school? And I said Arizona State. And he said, what did they teach you there? And I said uh, biochemistry. It was just kind of funny. But yeah, I would say the overall like hardest part of medical school was just the first year and kind of getting acclimated to everything. And once I found my circle of friends, it became a lot better because we were able to kind of lean on each other. But I would say the first half of the first year of medical school was extraordinarily tough in adjusting.
I mean, that just must have been a slap in the face. You get a bachelor's degree in biochemistry and then you don't pass the first biochemistry exam in med school.
I know I was a little miffed about that, but it's completely different. They're testing you on stuff like the Krebs cycle, and the real Krebs cycle is learning it and forgetting it. But yeah, it's stuff that I mean, I don't want to bash it, but some of it has little clinical relevance to what you're doing in the day-to-day life as a physician. And so I guess if you're dealing with like genetic medicine, then that's a little more applicable. But when you're on the wards, I don't think about the Krebs cycle.
No, and I don't think anybody would expect you to. Well, that's good. I mean, they say success obviously doesn't come without failure, and
Hmm.
that's kind of what tests who you are as a person and being able to overcome that despite the initial shock. It says a lot about your character and anybody else's character who's capable of overcoming something like that. So,
For sure. Yeah, it makes you a lot more resilient for sure.
oh, 100%, because you go in, nobody wants to go in and perform less than what they've expected for themselves. And I mean, I'm sure that happens quite a bit, actually. People probably start medical school and they don't necessarily know what to expect and take some time to adjust and find your groove, as I've heard a few
Hmm.
times before. So
Yes, it definitely does.
now, once you established yourself, you got a group of friends, you started your clinical years, what did you enjoy most? And what are some of the things that you took away that were the most valuable from those clinical years of med school?
Well, you really get to refine your craft because in the first 2 years of medical school, they'll teach you like some of the medicine. They'll teach you, how to do a history, a physical exam, but you're not really refining those skills until your third year and fourth year of medical school because we have what's called OSCEs, and these are like the standardized clinical encounters with patients. And so you'll practice with your classmates, taking a history, doing a physical, and then you'll do those on these standardized patients, but you're not actually doing a lot of it until you get to your third and fourth year of medical school where you're dealing with real patients. And so that adjustment is it's tough because you're very unfamiliar and the patients will see that you've only done this a couple of times, but it's an amazing learning experience because you get to refine your skills over the course of those 2 years. And even still, as a resident, as an intern, I'm still working on these skills. It's not like I'm a master of a history and a physical. um, each patient is going to require something a little bit different, and I think that's something that you also get a little bit better at because in the first 2 years of medical school, they'll like you have to do a full history and physical that you literally ask everything. And as time goes on, you'll see that you don't need to do as much and you can do more focused history and physical, which is a lot more relevant. Um, but yeah, I think you definitely learn a lot in your third and fourth year just by actually being with patients because you can only learn so much just looking at a textbook in the first 2 years of medical school. And so that's a big change.
Yeah, definitely. And huge on the path to mastery, which I appreciated that you mentioned because you go in, you start, and you're basically a fool. You don't know much.
Hmm.
And I'm told that it's very important to understand that going in and starting your clinical rotations, keeping that in mind as well, and just staying humble and understanding that it's a journey and you need to take the time to step by step go about that path to mastery.
Right. And I think the common mantra is, to be a master at something, you have to have at least 10,000 hours doing it. I'm nowhere near the 10,000 hour mark right now. So it's going to be over the course of residency. Um, it started all the way back in medical school where you start refining these skills and you just get better and better over time. And then you can become a master um, after you've accumulated enough experience. So we're at just different stages of the road right now. Mhm.
What would you share with a medical student who wants some advice on how to succeed in those clinical rotations? What do you think are some of the best practices a student should know going into them?
I think probably the best thing for a student to know is attitude is altitude. Um, the best thing is to always try and learn as much as you can. I don't like speaking as a resident right now. I don't really have any expectations as far as medical students in terms of knowledge, except very basic stuff. Stuff that every medical student should know. I don't expect them to know the nitty gritty of the treatment of some disease, but I think if a person comes into a rotation and wants to do well and they want to learn as much as they can and they have a good attitude and they're trying their best. That's what matters the most. And people appreciate that. There's a clear difference between students that come in um, that want to learn and they're trying to, take on as much responsibility as they can versus students that really don't care about the rotation and they really don't try and get much out of it. And in some sense, I understand it because, for example, going into internal medicine, when I was on my surgery rotation, I told my surgeon, yeah, I want to be an internist. I want to go into internal medicine. And he understood that. But I still wanted to learn as much as I could because you're going to deal with surgical patients sometimes. And knowing how a surgeon thinks about things is important. And then also just trying to learn as much as you can about that certain specialty so that you can apply it to your own. I think that's very helpful. So I hope that answers your question with regards to the difference between a good and a bad student and what they should have in mind going into their rotations.
Yeah, that's great advice, actually. And it kind of pops a thought into my head of just keeping an open mind because I had never actually thought of it like that. If you're interested in internal medicine, for example, and you're on a surgery rotation, it's valuable to understand how the surgeon interacts with those patients, the process before surgery and after
Hmm.
surgery, and kind of the things that occur before they come into your care. So that's actually a fantastic piece of advice.
Right. Medicine's a team sport. So you're going to be calling your surgical colleagues all the time for stuff, and they're going to be calling you for stuff because, what seems like a simple issue for me to manage, if they call me for something like diabetes, it's like, well, okay, I can do this. It's not exactly like the most mind provoking or thought provoking consult, but I'm going to do it because they have more important things to do. And likewise, if I consult them for something super simple to them, you know, I would expect them to have that same professional courtesy.
Well said. I like that analogy. Medicine is a team sport. So, as an osteopathic student, did you take COMLEX alone or did you take USMLE as well?
I just took Comlex because I knew as going into internal medicine, that's not something that I would have needed. The military doesn't really care if like which set of board exams you take. I think the big thing is for those in military medicine who are pursuing a more competitive specialty, you're probably going to have to take both set of board exams because there comes the possibility of going into a civilian deferred residency. And so for example, like if you wanted to pursue orthopedics, that's a very competitive specialty in and out of the military. So an osteopathic student would be expected to take both sets of board exams and then apply not only to all of whatever uh, branch of services MTFs for orthopedic surgery, you'd also be expected to apply for a civilian match.
And how many questions are on those? Like COMLEX 1 and 2? It's 270 or something like that? How is
Oh, it's
that?
a lot. I don't remember the exact number, but we're there for 8 to 9 hours for each exam. It's a long exam.
How do you even prepare for something like that? 8 hours.
Well, you take a lot of practice exams. It's kind of like running a marathon. My wife and I, we like to run. And so when you're preparing, like we did a half marathon together, you don't run the full half marathon. You're not running like, 13 miles every day. Like you build up to it. It's kind of the same pattern. You're not going to do 8 hours of questions in one sitting. I would do like 4 hours of questions, like do a half test and kind of build yourself up from there. But the mainstay of studying is just a lot of questions. Research has shown that if you're doing questions and doing that active recall and trying to put some critical thinking into your study routine, that's going to be far more effective than just reading slides or reading a textbook.
Well said. It is like a marathon. And on the topic of research, were you involved in much research throughout medical school, or are you involved in any now? Do you anticipate being involved in any?
As far as research goes, I was involved in a couple different case reports, nothing big, nothing like bench research like you would expect in an undergrad facility. And I think that's probably the best thing to do. If you want research in medical school, do more clinical stuff, do more case reports, and try and avoid a lot of the wet lab stuff because it's not likely that you'll get a lot of good like publications out of it. Publications are pretty important. Posters are good. If you can present at a conference of some sort, that's also really good. As far as research right now, I'm not involved in anything, but I do expect to get involved with just interesting case reports. Um, it's for research in medical school and residency, it's all about like the efficiency of it. Because if you want to do research, it's very important for like the application to residency and also to fellowship, depending on the specialty. But it kind of comes secondary to other things. So like your scores in medical school are the most important thing, like your board scores, your scores in your preclinical years. Those are the things that they look at before research. And so research is like an extra cherry on the top.
Right, right. And that's why I love this podcast because it's like I get to talk to guys like you who have been down the road before and hear some of that insight. So very
Hmm.
important to just have the basics settled first before you dive into some of that extra stuff.
Right. And I would say also, it's not like if you don't want to do research, don't feel compelled to do it because there are plenty of other ways to distinguish yourself. If you have an interesting hobby or if you have some sort of volunteering that you do, like there's one co-resident of mine in our class that used to be an Olympian. And so I imagine that's something that she focused on during her applications. She might have not needed the research. So it really depends on what you want to do. Um, I know competitive specialties will require research, but if you're aiming for something like internal medicine, um, research in medical school is probably not too important.
What sport did she compete in the Olympics?
It was synchronized swimming.
Wow, that's
Yes.
awesome.
Hmm.
That is awesome. Yeah, and the Olympics just finished up actually. And I watched some of those synchronized swimmers. They do some crazy moves.
I know it's very impressive.
Yeah, that's actually super cool. It's not often you meet somebody like that. Actually, ever, really.
Yeah, I like her. She's very impressive as a person.
Yeah. So, Dr. Goulden, as we wrap up this interview here, I just want to ask you, is there any advice that you think would be valuable to share with any undergraduate medical student or somebody else who's interested in medicine?
Yeah, so it kind of goes back to what I was saying about wanting to go into military medicine. You have to go into it for the right reason. And, the same applies for even those who are not going into military medicine and just pursuing a civilian career. You have to go into it for the right reasons. Again, a financial reason is okay because you're going to make a decent living as a physician, and there's plenty of opportunities for you. But if you go into it just wanting the money, there are other careers that would probably better be suited for you. You have to go into it because you care about people. And then the other thing is just expect to work a lot in your training. It's definitely a culture shock going from college to medical school and seeing how much you work. And then there's the same sort of level up of work and expectations when you go into residency. I think it's a lot more enjoyable because you're actually getting paid in residency versus medical school. But the difference is, you're working a lot more hours. It's completely different in terms of responsibility again. Um, so it's still a very rewarding field, but just expect to work hard. And I guess the other thing is also just the field in general. So something that has come up quite a bit in the past couple of years, and plenty of preceptors have mentioned this to me, is just the rise of mid-levels and um, how they're starting to encroach upon our practice of medicine. And in some cases, I understand that because when you're working out in rural areas, they don't have that same access to care that we might have in a bigger city. But at the end of the day, a physician cannot be replaced by a mid-level, right? A mid-level has their limits. They don't have as much training. They don't have as much knowledge. And so I would say that the big difference is going into medicine, you're going to come out as an expert and as a master of your craft. And so that's what you have to want. If you just want to have like a simple 9 to 5 job, work 40 hours a week, you're okay with not knowing everything, just go for the mid-level degree, like be a PA, or do something of that sort. If you want to be a master of your craft and put in that time, and there are going to be plenty of tears and plenty of hard times, but you come out of it knowing what nobody else knows, and you're the person in the room that people look to when there's a problem and nobody else can solve it, then be a physician. So it's very rewarding. Know that there's a lot of sacrifice involved, a lot of hardship. Um, I guess some level of disrespect from patients that don't care about you as much, or mid-levels that may not respect your position as much. But I think it's still very rewarding, professionally and financially.
That's great advice, great advice. And it reminds me of something one of my organic chemistry professors shared with me when I was a sophomore in college, when I was telling him about how much I was sacrificing in order to do well in the class. And
Hmm.
sticks with me to this day. He says, it's not a sacrifice if it's what you want to do. And tying that into what you mentioned about finding a deep-seated purpose within yourself that will sustain you throughout the challenges and hardships throughout a medical career on the path to mastery is so important, because superficial reasons like financial motivation or status or prestige won't sustain you throughout the overnight shifts that you'll be doing through residency, or the late night studying, or the 8-hour board exams. So, very good advice. And thank you for sharing that.
Absolutely. It has to be people focused at the end of the day. And, the gratitude that a patient gives you, that's something that can't be measured. And also just realizing, now that I've got a wife, and, you know, providing for her is important, providing for our future kids is important. And like everything at the end of the day comes down to people, finances and prestige or whatever. That's secondary. Your primary motivation has to be people, whether that's your patient or your family.
All right. So, Dr. Goulden, you're a very inspiring individual. Thank you for your service, and thank you for sharing this amazing advice.
Well, thanks for inviting me on the podcast. It was a good time.
Absolutely. Thanks again.